just in case, loved ones are watching in, I want you to be your sartorial best. Hi, Justine.
Afternoon, Russell.
We heard some great baby stories this morning.
Good.
We like baby stories.
They're always very, very warming, very positive.
Have you been to check your trees in your garden yet, Julie, after our discussion this morning?
No, it's cold out there.
It is bloody cold.
If the roof's intact, I'm not going out, and there'll be too much damage and I'll just get depressed.
Hi, Mel.
Good afternoon. I couldn't find my mouse then to take the mute off.
No worries. Hi, Joe. That's better, Mr. Burley.
Well, I should be corporate.
Yeah. Tell me
Russell?
when you think. Richard.
Afternoon. Live stream's running, Russell, so whenever you're ready to start, that's fine.
Okay, that's super. Thanks, Richard. We'll wait until 1 p.m. just in case any members of the public join us. Do we have any members of the public joining us today? Do we think, Gwenny?
I'm not sure. Joe, are you aware? Is Joe on the screen?
I've not been notified, but we do have some questions from the public at the end of the meeting, so they well might be with us throughout.
Okay, that's super. So it's 1 o'clock as I make it. Welcome everyone to this, the last board of the Worcestershire Acute Hospitals Trust before Christmas. I hope members of the public are staying safe and as warm as possible and are safe after the very challenging weather conditions for the weekend. Just before we get going, a couple of points. It is incredibly busy for all of our hospitals at the moment, and I want to thank our frontline staff in particular for the enormous efforts they go to 24 hours a day to try and look after our citizens as well as we're able. And a particular shout out to Chris Douglas and all of the operations team, Sarah Shingler, all of the nursing team, and Jules Walton and all of the medical team that we have, who are coping with those challenges so well, and the leadership you're providing as an executive group. I'm extremely proud to be your chair. The second aspect, though, is a word of apology. We are failing far too often to deliver the turnaround times that we want to achieve for you. It is because of the very, very strong levels of demand, which we'll come back to later, as well as some challenges we have within our system at discharging patients as quickly as we would like. But we do recognise that the consequence of those internal and external issues is that too many of our citizens are waiting too long to be seen, and too many of our ambulance colleagues are waiting too long to be able to hand over. But that's not for the want of trying, I have to say that. Okay, so without further ado, any apologies for absence, Joe? No, we don't. Super. Any new declarations of interest? Could you please raise a digital hand for me? Simon?
Thanks, Russell. I've recently taken on a role as the chair of the West Midlands Labour Finance and Industry Group. It's a voluntary post, and it's a network of organisations that bring government ministers together with businesses across the West Midlands region. I'll be updating my declaration of interest accordingly.
Okay, thank you very much, Simon. And Alex?
Thanks, Russell. I've recently been appointed Vice Chair of the NSPCC's Business Board, which also is a voluntary role. Okay,
both very good causes. Thank you for your volunteering, Alex and Simon. And I think just for completeness, I have retired as chair of Your Cherished since the last board meeting that we had, so if that can be duly noted as well. The minutes of the meeting held on the 8th of October. Were there any points of accuracy colleagues wanted to change on those? Please raise a digital hand. I can't see any digital hands raised. And I think we've completed all of the action points, but Gwynnie and Joe, just for the future, I did ask for us to have an action points arising section after the minutes, as per the other bits of the foundation group. So if we could just make sure that happens going forwards. Sorry, Tony, did you have a point of accuracy, or was it a point about the action points?
It was action points, if I may, Russell.
Of
it's
course.
minute 01124 on page 7 of 151. It was
Yes.
to do with the risk register. There's a
Yes.
question I asked about the risk posed by the change in BT provision and telephony. Vicky was going to provide a response on that. I guess it's been overtaken by events with her departure, but I think that's still outstanding. Thank you.
Okay, so if we can make sure, I was going to, Rebecca's hand shot up at that point. Rebecca?
Thanks, Tony. I'll arrange to meet with you separately, and I can take you through the full risk.
Okay, super. Is it a particular risk, Rebecca? Do we need to be worried about it?
It's a diminishing risk, actually, at the moment, Chair. And I'll be able to let Tony know about that. We're hoping to use some capital slippage to fund some of it this year.
Okay, super. Thank you very much. Any other matters arising that colleagues wanted clarification on? Okay, so we'll move on then, and it is an incredibly busy time for the NHS generally in terms of demand, as I've already touched on, as well as for our new government coming in. So lots happening in the NHS. Glenn, how are you seeing things?
Yeah, thank you, Chairman. I'd like to add my appreciation to yours actually at the start here in terms of the levels of demand that we're experiencing across the NHS, but particularly within our organisation. And I think that balance between managing the day-to-day pressures, but also making strategic change happen in the organisation, which we'll touch on in a number of parts of the agenda later. But then also that balance between the urgent care pressures and managing to maintain our elective activity and our cancer activity. And so huge credit to the teams that the volumes of activity in those planned care areas are still remain really high, which is helping us to reduce the waiting lists and treat patients more rapidly. So within my report, I talk about the single operating framework, which is just going through a refresh, and importantly is something that the new Secretary of State has signalled will be used as a mechanism through which organisations like ours are given more or less freedom depending on their performance. So I think it's an important one for us to keep a really close eye on in terms of where we are. What I will hope to see in the NHS plan that we'll be seeing in the spring is more of an opportunity for earned autonomy, and hopefully more of an opportunity to access discretionary capital for those organisations who can demonstrate that they're being run effectively and delivering against a number of indicators. And so what you see here in the report is a table that looks at the trusts in the foundation group, but also University Hospitals Coventry and Warwickshire, with the other acute provider who work in our two systems, showing the makeup of the current operating framework. As I say, it's going through a refresh, but I expect to see many of the features that you see there still as indicators. And one of the big ones actually is the staff survey. And we've just gone through a process of all of our staff filling in the staff survey. So we will see the outcome of that in the new year. That will have a big bearing on our performance against these indicators. And what you see in the colour coding there is in blue, you see the indicators that are in the upper quartile performance. You've then got the interquartile range in amber, and then in red, you've got lower quartile performance. So for us, you can see we've got 2 in the best performing section, 17 in the middle, and 10 in the least performing section. And some of those actually relate to the staff survey of the previous year. So I think our main aim for the staff survey this year is to ensure that we increase the number of people who fill in the survey, which we have, but then also to learn from the survey in terms of the views of staff in the individual parts of the organisation that we can hopefully respond to. And we'll talk about the values work that we're doing as well later. So we will keep bringing those performance indicators back. The other bit in that part of the report, it's good to formally recognise that we've been stood down from national performance monitoring for our cancer performance, which means that our cancer performance is in a much better place. So well done to the teams for pulling that off. I then referenced the insightful board document, and for those of you who want to look at the detail, there's a link within the paper to that. This is a new guide for provider boards. There's been a similar guide produced for ICB boards, and it signals some of the changes that we've seen over the last couple of years, including more of a focus on productivity within board time. Also, it gives some best practice guidance on things like integrated performance reports and the nature of board business. They actually use the integrated performance report that we have built across the group as one of the best practice guides within that. So in looking at it, I think we're broadly consistent with the recommendations, but Gwenny will be giving this a more detailed review, and we will no doubt bring that back when we've done so. And then finally, more from our great teams, we recognise the accreditation of our paediatric surgical hub at Kidderminster. I know that Professor Tim Briggs, who led that, was incredibly impressed with the submission that we made for Kidderminster and the work that we're doing over there to ensure that we've got the best possible paediatric surgical capacity for our patients. So well done to the teams for achieving that accreditation. Happy to take any questions.
No, thank you very much, Glenn, and thank you for the work I know you get involved in at a national level, which helps us have a level of voice beyond our region, which we're very appreciative of. Any questions or perspectives to Glenn? What's worrying you most at the moment, Glenn?
Well, it would be the pressure that everyone's under at the moment in terms of trying to ensure that we keep things safe as we go into the winter. And it's felt like it's been a tough week or so for us, which we'll reflect on in a moment. But I'm also conscious that the worst of the winter is likely to be in the kind of January, February period. So the winter plan that we discussed in workshop this morning will help us through that, but also the incredible hard work of our teams will do so too. But just trying to make sure we keep focused on keeping everything safe and hopefully working with our wider system partners to hopefully manage demand a little bit more than we've seen, and maybe help us with a bit more flow in the system as it gets even busier than it is today.
Thank you, Glenn. Well, that segues us quite nicely into the integrated performance report, which is always looking slightly in the rearview mirror. So, Stephen, it would be good in your introduction to give not just a review of the IPR, but also how we're seeing things at the moment, sort of lifetime more. Over to you.
Yeah, thanks. And picking up on that theme, I wanted to start with the kind of pressure that we're seeing around our urgent and emergency care pathway. So in the report, it highlights the increase in attendance, particularly from walk-ins. And I think what I wanted to bring to life for board was, I think sometimes you can associate an acuity with that, which isn't actually what's experienced in the ED. So these can be quite sick patients that are making their way to our ED. So there isn't a simple translation there. And that is causing pressure both internally in the department, but also for our partners with West Midlands Ambulance Service, who are experiencing far too many waits and far too many ambulances being congested on our site. So there is a particular, there is quite a lot of work we're doing around that, and we took the board this morning through the winter plan that we've enacted. But I think, as Glenn highlighted, there's a real tension between managing that here and now and also trying to put in the things that will resolve it over longer length of time. The other bit that I just wanted to draw out, particularly as this is meeting in public, we are seeing increasing infections, particularly around flu and COVID. And I think anything that people can do to keep themselves safe, that's both colleagues and patients, for vaccinations and looking after yourself in those things, really encourage people to do that, because it's having quite an impact in the department, but also in our beds. We are seeing increase in loss of bed capacity due to those infections. And that pressure in UEC kind of runs through the rest of will run through the rest of the performance reports that you'll see. So we're particularly worried around the quality and the patient experience of either waiting too long, or on our inpatient units where we have to do things like boarding, which none of us want to do, or move into temporary escalation spaces, just to try and keep an overall level of safety in both hospitals. And then for colleagues' experience, this is really pressured and it's really, really difficult to manage. So from a HR and workforce point of view, and that translates into things like our sickness levels and how people experience it, we're really trying to have a focused look at how we support people through that. And then linking the workforce to the finance, the other bit it does lead to is it puts pressure on our finances, because we have to staff those areas. And predominantly we have to do that through temporary staffing. And again, that's not the best solutions to these in the long run. So we have to balance those off as well. The one positive that we are seeing that I think has been referenced is the elective and cancer. And I think this is where a strategic decision and our plan to keep moving on that is really paying dividends, in terms of how we've got the elective hubs at the elective site at the Alex and also at Kidderminster. So what we're able to do is minimise the impact of that urgent care pressure on those services, and we balance that really carefully. But as Glenn shouted out, a particular shout to Kidderminster Treatment Centre, who are really working through a lot of our elective backlog, and that's good for patients, but it also impacts the system overall in terms of reducing that urgent care demand as well. So there were the main bits I wanted to pull out as a theme. And the other one to highlight for board that I think Neil might touch on is, in terms of finance, there's an awful lot happening in our capital programme. We've received some money from NHS England that we are looking to spend, but we had put aside some of our own capital programme to do that. So there's an awful lot of work going on there. And one of the things we're really, really keen to do is to try and tackle our backlog maintenance and making sure that we keep the places moving and doing what they need to do, but also anything we can bring forward that has a revenue impact for next year in a positive way. So there's an awful lot of work in that space that I just want to bring to life for board. They were my bits, Russell, and then I think hand over to the sections, if that's all right.
Very helpful. Thank you, Stephen, and thank you for your leadership. Shall we move on to the individual, and then after each individual, just ask any questions? So I think, Chris, you're first up on the engine room.
Thank you, Chair. So I'll take the report as read. Just a few key points I would like to draw board attention to, some of which will be repeat of what other colleagues have said. So I think the positive around cancer is the stepping out of national tiering for cancer and diagnostics, alongside the previous de-escalation from tiering for elective performance, just recognising the positive and sustained performance improvement from all our clinical and operational teams. There are some areas I remain concerned about in that space, however, particularly overall our ability to address the underlying capacity needs to meet constitutional standards going forward. So whilst we're in a good position around expectations this year, we clearly have some way to go to meet constitutional standards. We are seeing positive progress in the skin performance and the planned recovery of 31 days, which I know has been a concern for colleagues for some time, but we expect that position to improve in Q4. Around elective recovery, overall, clearly ended October with 57 patients waiting over 65 weeks. That was 57 patients more than we wanted to have waiting that long, clearly. But November is an improved position and we're continuing to work towards delivering 0 in December. However, current operational pressures that Stephen's alluded to, the need to stand down some elective activity as a consequence of the current position does present a material risk to that. Whilst we've kept cancellations of elective surgery on both acute sites to a minimum so far, clearly, depending on how long we find the operational pressures continuing into December, presents a real and material risk to that, but we'll monitor that on a day-to-day basis. The positive progress on that front, though, is the continued mutual aid we're receiving and additional internal actions we're taking around our additional sort of traditional additional waiting list activity, as well as the sort of Super Saturday and those GIRFT high intensity lists that are proving fruitful. There's more to do on productivity around the elective and cancer side, absolutely, and we're doing that with support from group colleagues from Swift Clinical Services, particularly in reaching in terms of our theatre programme, and we'll be looking to adopt a similar approach to Y-Valley around the productivity board approach into Q4 in terms of how we're managing that. I am particularly concerned about the number of patients who are being cancelled on the day of their surgery. There were 59 reportable cancellations in October, and that's alongside additional cancellations for clinical reasons and patients who chose to cancel their operation on the day. It presents not only a lost capacity opportunity for those patients where we have to cancel them, but also a missed opportunity for other patients who could utilise that slot, and does have an impact on our financial performance given the lost income associated with it. That really leads me on to the urgent and emergency care and the flow element of the operational performance, which does remain my biggest concern and one of the biggest risks from an operational performance of the organisation. October and November have seen high numbers of attendances. So October, as the report says, 7.8% up compared to last October, but November is 9.6% up compared to last November, which equates to almost 1,000 attendances more than the same period last time. So these are not insignificant numbers that we're talking about. Ambulance handover delays, we are seeing too many taking more than an hour, and we saw 36 patients over 8 hours on the back of an ambulance outside one of our emergency departments in October. We have put an enhanced escalation process in place all the way up to the managing director, 24 hours a day, 7 days a week for any patient who is at risk of waiting more than 8 hours, which clearly we don't want to have to utilise, but we have found ourselves in a challenging, very operational position in recent days, which I'll come on to briefly shortly. Clearly, we recognise the risk of keeping those patients outside, both for those patients as well as the patients in the community we're unable to get a response to. October and November have been challenging for ED in other aspects as well. Clearly, we had ED flooring work on the Worcester site, and we launched the new ED EPR in November, both of which have had an impact on our performance, but have now been completed, and we're still working through the implications of the ED EPR as we work through and getting used to the new system operation in the department. Temporary escalation spaces and what we've been using recently. So we have had up to 43 patients in spaces that we do not routinely put patients. That includes temporary escalation spaces and additional areas we have opened in extremis. If you add that to the average number of DTA decisions to admit in our emergency departments, on the Worcester site in particular, that's approximately 80 patients who should be in a hospital bed, who we can't get into a hospital bed in a proper bedded area. And that's the absolute focus in terms of our internal focus on flow in the organisation. So in terms of the work we're taking around Pathway Progression Hub, working with partners, the focus on length of stay being led by our CMO team, but also the work we're doing with system partners around community general medical beds. There is more work we absolutely are doing as part of the winter plan that members will have heard more about this morning in the workshop. I would just like briefly to touch on the current situation in our hospitals, if I may, Chair. We have been experiencing significant challenges around flow in our hospitals in the last few weeks. That has led us to declare a critical incident on a couple of occasions. I just want to express my thanks to all colleagues who have taken extreme actions to support that internally and externally in terms of the actions we're taking to keep our patients safe. I am really cognizant of the impact it's having on the health and well-being of our staff. And we're just making sure that we are looking after our staff, because if we don't look after our staff and each other as colleagues in this organisation, we'll not be able to look after the patients in the way we would like to. We'll continue to work with partners around the response to the critical incident, and clearly we want to de-escalate that as quickly as possible. That's all I wanted to say. Thank you, Chair.
It's a very comprehensive overview of the canvas, a very broad canvas of things that we are working on. Questions and perspectives to Chris. Glenn?
Yeah, I just wanted, if I could, Chair, to pick up on the patient-initiated cancellation issue. It's a feature of both outpatients and at times elective activity, and obviously something we're trying to ensure that we minimise. So we've been working across group with the organisation Helpforce, who support volunteering. And we've just signed up to a programme in all 4 trusts in the group where we will be working with Helpforce to identify patients who are more likely to do not attend, and then to contact those patients to encourage their attendance, and to, if they're not attending, to reuse those slots for other patients. So that should increase our productivity in both outpatients and inpatients quite a bit more.
Thank you, Glenn. On the subject of efficiency, you referred, Chris, to the reduction in efficiency in ED due to the launch of the EPR. Colin asks, how long do you think it will take to get back to where we were?
So it's a difficult one. The modelling from other trusts has suggested a bounce back within a matter of a few weeks. I think given the time of year that we've launched ours and the other implications of the operational challenges, it's more difficult to give a specific timeline in terms of that. There are some specific issue or challenges with the EDPR that we're working through with Rebecca and the team as part of that, which we hope to resolve this side of Christmas where we can. But I understand there's quite a list of other bits that will make it smoother. But I would hope to see more of a return to normal into the new year.
Okay, thank you, Chris. Keep us briefed. And Simon, then we'll move on.
Thanks, Russell. Thanks, Chris. In the minutes of the previous meeting, we noted the increase in walk-ins, and obviously it's in the IPR as well, the increase in walk-ins. I just wonder what specifically we're doing to address that, if you could sort of update us on how we're managing that, and any mitigation we might be working with partners to stop people who don't need to come to us potentially, but those who do need to come to us quickly, or more quicker. Second question was just, I'm assuming we're not unique.
Sorry, Simon, can we do one at a time? Otherwise,
for sure.
So on that first one, Chris?
Yeah, certainly. So we are in active conversations with system partners around what else we can do around stemming the flow of patients walking in who do not need to access emergency department facilities. I just want to be really clear with the public that we are here 24/7 for a service. If you need emergency department services, please do continue to access. But we just want to make sure that we are exploring all the options. So we do have the single point of access in the system that GPs and other healthcare professionals are able to access, that can make sure that patients are able to access the right service for their needs. There is also this week an ED audit happening, where colleagues from the ICB are talking to our patients in our department, particularly on the Worcester site this week, with a planned date for the Alex sites in the future, around them really understanding where else those patients have tried and what have been the blockers to making sure they're able to access the right care needs for their particular conditions.
Okay, thanks, Chris. And Simon, your second question?
Second question was, I'm assuming that this is not unique to us, but that the region and indeed nationally this is being repeated, the sort of pressures we're under.
So yes, in terms of overall pressures, there has been an increase in pressure, particularly, it's definitely, we can see it regionally in terms of those pressures. We're not unique in terms of some of the numbers of handover delays we are experiencing, but we do seem to be particularly challenged with the length of time that sometimes we seem to have patients outside of our departments on the back of an ambulance. We're certainly not unique in that respect.
Okay, thanks, Chris. Thanks for your hard work, and keep going. But please keep us briefed. We're here to help. We'll move on then to quality and safety. Sarah, what would you care to pull out?
Okay, thank you, Chair. So if I just start with infection vector control, we have C. difficile remains a concern for us as a trust, and is still showing a special cause variation. We are reviewing our C. diff action plan, and we're linking in with the ICB as we are seeing a rise regionally and nationally to try and understand what else we can do. We are, as Stephen mentioned, seeing a rise in flu cases, and this is having an impact on some bed closures, which obviously is putting further pressure on operations across both sites. We have approved our viral respiratory plan, and that is now being implemented across our divisions. And the threshold triggers for mask wearing haven't yet been reached, although we are constantly looking at that under review. Moving on to complaints, we are still not meeting our 25-day compliance target. However, we are making improvements, and I'm pleased to say that the surgical division are on track to deliver their trajectory on removal of all of their overdue complaints, and that improvement is being sustained. Moving on to falls and pressure ulcers, we have continued to see an increase in falls, and again this remains in our ED departments, mostly at Worcester, and that is associated with our ED overcrowding and the amount of corridor care that is taking place. However, I'm pleased to advise that we've not had any falls which have resulted in harm to our patients. On a positive note, we are continuing to see a reduction in our hospital-acquired infections, and that's month on month, with further increases in compliance with training. And again, we've not seen any harm caused to our patients as a result of hospital-acquired. So I'll stop there, Russell, and happy to hand over to Jules.
Jules.
So, thank you, Chair. So from the quality and safety perspective, regards to the work the Office of the CMO is undertaking, our summary hospital level mortality indices remain within the expected ranges, which has been the same now for the 57 consecutive months. We are doing some work around that, though, as previously alluded to. We have identified some potential changes at the Alex site, so we're looking at that, and that is referenced in our learning from death reports. Compliance with the principles of antimicrobial stewardship is still showing some improvement, which is good, although kind of essentially stable. Some slight areas of improvement, we continue to work on those. Sepsis, as board will know, is still, or sepsis screening is still remaining a challenge, but we have recently appointed a newly identified clinical lead for this area, so we're hoping that will help drive improvements that we need in that space. And we're continuing our work on the pathway for our patients with who've sustained a fractured neck of femur, recognising that we need to see some sustained improvements in that area and to deliver better care for that patient group. I'll take the rest of the report as read, Chair, if that's okay.
Thank you, Jules. Julian, anything you'd like to add, just as your handsome pictures on the board pack?
Nothing else to add, thank you, Chair.
Okay, thank you, Julian. Any questions or perspectives to Sarah or Jules or Julia? Okay, thank you very much. Thank you for your hard work. Now we'll move on then to our people update, and a very busy time for all of our staff, as we've talked about, both the frontline but backline as well. People in admin and managerial roles in the NHS often get a bad press, to use an old-fashioned phrase. I'd just like to thank all of those who behind the scenes in different ways help make this engine run smoothly. and we're very appreciative of your hard work. Ali, and what would you care to pull out of your report?
Thank you, Chair. Points to highlight from this report, you'll find similar themes to that we've reported previously to board, in that our vacancies are doing well. We're less than 7% vacancy rate, which benchmarks well against other trusts as well, and places us in a good position from a workforce stability point of view when you add that to our turnover, which also benchmarks positively against other organisations too, and Model Hospital. That said, we know there are some hotspots, some professional technical roles, healthcare assistant roles, for example, where we do need to keep a constant eye on those areas to make sure that turnover doesn't increase disproportionately as well, because we know they are higher turnover roles. Despite that stability, we do see the continued pressure on agency and bank usage for all of the reasons that we've talked about already in today's board session. What we are seeing this time in the report that started to reflect more positively is that the way that we procure our agency staff now is changing, and we are seeing some sustained improvement in terms of a reduction in breach agency arrangements. And what I mean by that is the cap that NHS England set for agency pay. We need to report those breaches month on month if we exceed that, and we are seeing that that is starting to reduce now. We've also seen off-framework reductions as well in agency procurement. That said, we know that reliance is still high on agency and bank. We absolutely couldn't run our services without that support, and we're grateful to that temporary workforce, but clearly it's not a desired state. We would wish for a more permanent solution and a reduced reliance on that agency workforce as well. From a positive perspective, statutory mandatory training is still in a very positive place. We've seen some improvement in some areas around appraisals, but we do know that job planning remains a concern. It is highlighted in our risk register as well, and there are some particular hotspot areas, unscheduled and emergency care being one of them, where we know that our job plans are not at rate of completion that we need. There is an area of concern that we're working with divisions on to try and improve that job planning state. And although we're seeing some improvement, it isn't where we need it to be. I'd like to finish just by extending my thanks to everybody who has taken time to complete the staff survey. It's not mentioned in my report, but we look like we're on track for a 46% return rate from response rate, which this time last year we were reporting about a 31% response rate. So it's a marked improvement, and huge thanks to people that have taken the time to do that, and some divisions and teams that have more than doubled their response rate, which is tremendous, and we really appreciate that. Happy to take any questions. Thank you.
Thank you, Ali. Questions and perspectives, Karen?
Thanks, Russell. Thanks, Ali, and congratulations to you and the team on the staff survey stuff. As you say, it is a massive improvement. I just wanted to go back to the what you were saying about the agency costs, and really align it to what we've been talking about for large parts of the day, really, in terms of the additional activity, the additional attendances, and the work that we're having to put in place around the winter plan. And I guess my question is, I don't know if it's you or Neil or whoever, actually, maybe Chris, are we clearly segregating those additional costs in agency as against other costs? Because, you know, in a couple of months' time, we'll be looking at no doubt increased levels of agency and bank, and, you know, one would react differently to that which is allocated to the additional activity as against other activity.
Point understood. Neil, are we sort of separating out things in the way Karen suggests would be helpful?
Yeah, so we do have separate budgets for all of the temporary capacity that we've got open, flexed capacity around winter. It's not part of the financial reports that I've got here today, but I'm happy to share those outside. But we do record them separately, yeah, so they can keep track.
Okay, thank you, Neil. And any other questions to Ali? Okay, thank you very much, Ali. So we'll move then, segue nicely into the numbers. Neil, how are the numbers looking at the moment in these very difficult times?
Yeah, thank you, Chair. Yeah, so month 7, we saw the funding of the backdated pay award and indeed the payment to staff in respect to the backdated pay award. So you'll see significant movement in the month in terms of both income and expenditure. As with most organisations, there was a shortfall in respect of the pay award nationally. Locally, our ICB has supplemented us with that funding, so net nil impact of the pay award to us as an organisation, which is great. And that's fundamentally meant that we are able to report year to date that we're pretty much on track. So we've seen a small improvement in the month of 0.4 million. Generally driven by underspends against our insourcing reserves and a little bit of supplement from the balance sheet. So income, if we exclude the drugs, the pass-through drugs and devices, we're pretty much on track again around our elective income targets, which is great. We've been able to put in some or reflect some risk in respect of diagnostic income into the position year to date, which has been offset by the funding that we had got for industrial action. So we hadn't been recording all of that year to date, and some income from the Counter Alliance, as well as we've released some money again, 0.4 million from the balance sheet. Slightly under against the or favourable against the employee expenses. Again, we're seeing slippage on some of the developments, particularly in respect of the 5th endoscopy room. And again, we supplemented some of those costs from the balance sheet, but we have got an underperformance against the CPIP year to date, 1.1 million partially has been offset by those underspends elsewhere. In terms of our operating expenses, 0.1 favourable, again, after stripping out the pass-through drugs and devices. We are seeing pressure, as we've outlined from an activity perspective, feeding into a number of the budget lines, but we've got some underspends in respect of utilities and the insourcing reserves, as well as some non-recurrent funds that we've put in again from the balance sheet. So we undertook a forecast a couple of months back now. Detailed forecast was undertaken with the divisions, and we've been tracking that on a month-by-month basis, along with what risks there are to potentially delivery of that forecast, and indeed whether there are any opportunities in respect of an upside. So you'll see there is quite a large range. We are dealing with a number of downside risks still, and clearly we've had the conversation earlier around winter. We had set aside around £2 million for winter this financial year. That's significantly under pressure already as a consequence of some of the actions that we've outlined earlier. Subject to mitigation of those risks, at this point, not proposing that we change the forecast. We're still forecasting it will achieve our plan. If we can mitigate those downside risks, then there is potentially an upside opportunity based on some of the opportunities that we've looked at. So that's the forecast in terms of where we are. Stephen mentioned capital. Just like to touch on capital. As Stephen mentioned, we got 6.8 million of additional funds in, but given that we've only spent at month 7 4.75 million of what will now be a 24 million plan, we've got a lot to spend between now and the end of the financial year. So we've drawn up some schemes. The plan has slipped from this financial year. We've drawn up some schemes that are really pulling forward from next year and looking at opportunities around where we could benefit revenue savings from LED lighting and those sorts of things, just to make sure that we do spend the resource. Clearly, if we don't spend the resource, we would lose that resource. And clearly, given that we do have a significant challenge in respect of backlog maintenance and replacement programme, we need to take every opportunity to spend capital that is given to us as a free good. So in the next week or two, we'll circulate something for the board's approval outside of the meeting if we could, and then we'll bring it back for retrospective approval at a future board meeting. But we do need to make those decisions in order to ensure that we do spend the money before now and the end of the financial year. Quick one on cash, if I can. Clearly, because of our financial program, our capital program, sorry, from a cash perspective, we've got a lot of cash at this point. I'm not envisaging that we'll have any cash challenges at year end, other than if some of those downside risks do materialise. So I'm not projecting that we'll have a cash problem at this point during the year. Just very quickly in respect to CPIP, because I think that's important. So we're on track. We're overperforming against our CPIP year to date, which is fantastic. Of course, 0.5, 0.6 up on the CPIP. Just a note of caution: 4 million of that, just over 4 million of that, is non-recurrent, and therefore we'll carry that as a challenge into on our underlying budget gap into next financial year. So we just need to be sighted on that and keep pushing as much as we can on CPIP delivery. Happy to take any questions, Russell.
That's helpful, Neil. Thank you. Questions and perspectives to Neil? Well, it's good to be in this pretty solid position to describe it, given previous year's performance, Neil, so thank you. Team, we need to up the pace a little bit as we're running a few minutes behind, but we're over to the important issue of the perinatal safety report. Had a lovely patient story about preterm babies this morning at the board workshop, but Justine, what would you care to pull out?
So, in nature of time, I'll take the paper as read, but I just pull out, you'll see there that the KPIs around training are broadly improving, and pleased to say that we've overperformed in all of the areas that we need to meet our CNST requirement. Sickness, absence in the workforce, you'll see, is not where we'd want it to be, and there's still more work to do there with our HR partners. For the first month in a long time, we've met our booking by 12 plus 6 weeks KPI, just at not over 90% there. The new target is by 10 weeks, and we have launched our maternity self-referral on the 1st of November, so we're optimistic that we will be heading in that direction quite soon. Our perinatal mortality rate, pleased to be able to report that we continue to have a lower than national average rate, and that continues to be driven by our reduced stillbirth rate, and can only really be linked with the high levels of implementation of the Saving Babies Care bundle, which is now to be validated tomorrow, but around 94%. At QGC, we had quite a lengthy focus on our CNST evidence. We're currently sitting at a strong 9 out of 10 with some vulnerability in element 1. I do have now received some further evidence, and I need to have a conversation with our colleagues at NHS Resolution. If that evidence is accepted, we will be declaring 10 out of 10 for this year's CNST programme. And just to finish off there, you see the heat map. We are in a sustained position. We remain green on the heat map, and that sits us in a position of about 8th out of 21 trusts across the region. And I'll stop there and take any questions. Thank you, Chair.
No, thank you, Justine. Any questions or perspectives to Justine? Karen?
Hi, Justine. Thank you. Comprehensive report as always. You won't be surprised to know, I just wanted to pick up on the sickness absence, and particularly the maternity support workers. I mean, I've seen this before in other organisations where that group is seems to be particularly high, but we seem to have had a significant jump from I don't know which month these are referring to actually, but from one month to the next. And I'm curious about what your views and feelings are as what's behind that, and what else we need to put in place to stop that drift.
Thanks, Karen. Yeah, there's a few things that I think are driving it. There's a little bit of seasonal variation in there, and you'll see that showing in the other groups. However, the majority of those staff are off with long-term non-work related stress issues that we're trying to support those members through. Having said that, we have also had quite a number of vacancies in that group as well, which won't be helping, and we do have quite a lot of turnover in that group. We are looking at how we recruit people and making sure that we're quite realistic in what the role entails. A lot of feedback that we've had from staff that have come for a short time and left us is it wasn't the job that they thought it was going to be. And it is quite hard. So we're thinking about introducing taster days for those who are considering a job in maternity services as a support worker, so that they can just have a little bit of an introduction before maybe they commit to full-time employment.
Thank you.
Yeah, no, my anxiety is on the sickness level as well. To put it into some context, an 8% sickness level is almost 4 weeks off a year per individual. So it's a big number. So, and that's just the RN rate, which I'm looking at. So it is a big area of focus that we need to get on, because it puts more workload onto those colleagues who do come into work. And Simon, then we'll move on.
Thanks, Russell. Thanks, Justine. Just a big shout out to Lucy Kay, the patient experience midwife, who gave a very good presentation last Friday to colleagues from the Foundation Group on the co-production that we're doing with the Maternity and Neonatal Voices Partnership. Great progress, and it was a great presentation. Thank you very much.
Thank you, Simon. Thank you, Justine. Well said. We'll move on then to the safe staffing reports, and Sarah, back with you and Justine on this. What would you care to put out?
You want me to go first, Sarah? Okay, so I'll do the safe staffing for midwifery. Obviously, we've already talked about the sickness. You'll see there were no red flags reported, which is excellent in terms of the one-to-one care and the supernumerary status of the shift leader. It was a busy month and it made it quite challenging to meet acuity, but we did maintain safety on all shifts with deployment of staff from different areas. Whilst unpopular, it needs to be done to ensure that safety. You'll see there that our vacancies are reducing, and the expected 6 whole-time equivalents that I've referred to in that paper did arrive in November. We've made the offer of the final vacancy post. 16 whole-time equivalents are now expected in February, and that will put us in as close to a 0 vacancy position as you can actually get to, with another group of students qualifying in February as well. So any turnover between now and then, we will be able to address quite quickly with that next group. So generally an improving position, but I obviously take your point around the sickness absence. Thank you.
Justine, do you want to cover off nursing, Sarah, and then we'll take questions afterwards?
Yeah, no problem. Okay, so for nursing, staffing on paediatrics, neonates and all adult inpatient areas were maintained at safe staffing levels throughout October 24, although I will just note that how challenging it was for neonates to actually sustain that throughout October. And we do remain compliant with National Quality Board safer staffing recommendations. We have had reduction in agency spend and average hourly rate, and this does remain a focus. We are continuing to demonstrate sustainability in the reduced usage of tiers 2, 3 and 4, and in the removal of off-framework agencies in our general areas. I'm pleased to say that all tier 1 agencies are now capped, with the focus moving forward to look at that continued offset of agency with bank, specifically for registered nursing. And also pleased to note that we are continuing to improve our vacancy rate position, with registered nurse vacancy rate currently sitting at 3.96%. And when we look at model hospital benchmarking data, that currently sits at 9%. And a healthcare support worker, although at 9.3%, that is an improving picture month on month. And I'll stop there, Chair.
Thank you, Sarah. Any questions to Justine or Sarah on safe staffing? Okay, super. Thank you very much. Well, Melanie, lovely to see you for our Freedom to Speak Up update. Just before I hand over to you, just to say to members of the staff who may be watching this, freedom to speak up and civility in the workplace are absolutely key value foundations for this trust. And if you are the subject of bullying, or you see bullying, if you are the subject of racist or sexist, misogynistic or homophobic comment or trans comment, or you see it, please speak up. It's absolutely your right, and we as an organisation want to hear your voice. So with that introduction, Melanie, what would you care to pull out of this report?
So really positive. We had the advent of the training in June, and that has seen an increase in concerns being raised. So we are now at 85.7% with our speaker training compliance, which I think is really good in that short space of time. And we're nearly ready to go with the listen up for certain groups of staff. So as it stands today, we're at 102 concerns raised, which is the same as was raised in the whole 12 months last year. So that's really positive. But the other big positive thing is that we've decreased from 45% anonymous to 25% anonymous. So people are feeling that they can speak up with, although their anonymity might be maintained by me, they're still able to speak to me. So that's a real positive. We did a series of hate crime sessions in October that were really well taken up, and people on the gallery also attended those, and I think that was a real positive as well, because it identified the 5 protected characteristics that are classed as hate crimes and how we can access the police and work with the police as a trust if that's the necessary moves forward. Continues to be on attitudes and behaviours, the predominant concerns, but I continue to work with certain divisions, directorates and staff groups to tackle those and help them address those. I think that's it in a nutshell. I'll keep it brief.
No, thank you, Melanie, and thank you for the work you do, because you do at one level set the tone when people do speak up about the importance of them feeling free to do so and safe to do so. Questions and perspectives, Glenn?
Yeah, I just wanted to add my appreciations for that as well. I mean, I think that those stats that show how many are now anonymous is really encouraging, because it indicates a sense of trust. And I think similarly with the staff survey response rates, it's good to see those increasing. I think the challenge for us all will be that we listen to the voices of our staff and act on all of those. But it's an encouraging indication at the moment, isn't it?
Absolutely, Glenn. And I think one of the things we covered off in the workshop this morning was the importance of, when you're in a leadership position, understanding the unintended power of your role, and being sensitive and understanding of colleagues in those situations. So I think that's a lesson for all of us. Melanie, keep on doing what you're doing. If you want us at any of the networks, just reach out that you're aware if they need any help. Just we're here to help. And in the meanwhile, if I don't see you before Christmas, have a wonderful Christmas and New Year.
Thank you. I should stay and see the rest of the meeting through.
Oh, you're very welcome. And next up is the Quality Governance Committee minutes, the verbal update. I think Sue was going to cover this off for you, Julie, wasn't she? Because she wasn't. You were.
She was. I think she's just departed, but we did have a handover, and I think there were no escalations, but she did want me to point out that on page 4 of the minutes, which will be corrected, it reads as though it's in section 2.4. On average of 1,576 incidents, 20 of those resulted in a patient death. That was not causation, that was a correlation, and that will be corrected in the next set of minutes. And Sarah's nodding, so she already knows about that. The following meeting, which we'll bring at the next board meeting, was a very long meeting, and there will be some escalations from that, which we'll bring to the next board meeting.
Okay, thank you, Julie. Thank you for chairing that meeting. Any questions or perspectives to Julie, or anything you want to add, Sarah? Okay, we'll move on then to the Audit and Assurance Committee meeting. Colin, over to you.
Thank you, Chair. We held a meeting in November. The minutes aren't attached yet. They haven't been quite finalised. There's a couple of issues that the committee felt it wanted to escalate to board. One was a confirmation that the internal audit report on job planning, which raised a number of issues, has now been handed over, so to speak, in quotes, to the People and Culture Committee. We agreed at the Audit and Assurance Committee some revised timeframes which were more reasonable in terms of the expectation of implementing them. But now that's moved on appropriately, in my view, to Karen's committee. The other thing which I wanted to flag was that we had a very helpful, if not somewhat frightening, presentation on cyber security. And we received assurance that we're doing the best that we can in this area, but of course it is incredibly challenging, and we continue to have this rated at 20 on the risk register. There was one specific point that we have within the trust a number of backlog old applications, and there's a backlog maintenance issue with those because some of them are not supported. So as they get older and older, that they will be more and more vulnerable.
but that's something that the execs are aware of and they're working on.
Okay, great. Thank you, Colin. I think the whole issue of cybersecurity for members of the public is a far more frightening thing that I think we're normally made aware of in our day-to-day life. Questions and perspectives to Colin? Okay, thank you, Colin, and everyone involved in that committee. We'll move over then to the People Committee. And Karen, anything you particularly like to pull out?
Thank you, Chair. No, the minutes from the 7th of October meeting covered a previous board, and I think they're there for any questions anyone want to raise. We have had a further meeting since then on the 3rd of October, and just a couple of points to raise from that. I mentioned briefly this morning, but for completeness, we had a staff story which related to a member of staff who'd raised a concern around sexual safety. And the reason I want to raise it is A, because it was commendable that the member of staff felt able to raise that, and B, that the department involved responded extremely positively and very, very swiftly. So it was, whilst unfortunate the incident happened in the first place, the response was very encouraging how that was handled. The second quick thing is we took a paper on a proposal around reciprocal mentoring, which was very much supported by Stephen and other execs in terms of something that we wanted to take forward. But we just want to do some refinement about the parameters around that before that is finalised. And very quickly, the last thing to flag is that we took papers on both the race equality scheme and also the disability equality scheme, which will go forward for approval. Well, they have been approved, but would go forward for publication. And the only area to flag there of concern was that there was our outcome on the disability equality scheme was not quite as yet where we would want it to be. So we're putting a plan of action in around that.
Very comprehensive. Thank you, Karen. Thank you. Any questions or perspectives to Karen? I mean, Karen has sort of touched on a little bit in your committee minutes. I just want to thank all of our network leads who do a great job supporting staff from different networks or interested in different networks across the organisation. That they do it often in their own time, go the extra mile. So I'd just like to publicly thank all of our network leads for the work that they do. Okay, we'll move on then to the foundation group for board minutes of November, which I will just take as read. If there are any points of accuracy from board directors, could you raise a digital hand for me, please? Okay, so they will go forward with their action points arising to that meeting. And then we've got the communications update. Richard, please.
Thank you, Chair. Good afternoon, colleagues. I take the paper as read. It's a summary of some of the bigger pieces of work undertaken by the comms and charity team. And I have tried where possible to put some kind of impact assessment, either in terms of reach or impact or benefit to the organisation. A couple of points I'd tease out is our work really succeeds when we're working in partnership with other engaged teams across the organisation. And a great example of that, I think, is the staff survey, which Ali's already talked about. I've set out there some of the comms activities that we undertook, but it's really the energy and enthusiasm of the HR and OD teams and the divisional leadership teams and other senior leaders that have really brought that to life and helped us deliver the benefit that we hoped it would have. Couple of specifics. We continue to build from a comms point of view on developing the source as the kind of go-to information point for colleagues across the trust. It's still being very well used, and we've tailored the weekly comms update, moving from Worcestershire Weekly to the Worcestershire Source to help drive more traffic to that site and align to those key internal comms channels. And for the charity, we've now progressed plans for our lottery, which we hope to begin canvassing in March, with the first draw to take place during summer 2025, and we hope that after covering the initial startup costs, that will be a significant and regular income generator for the charity to support a wide range of projects, including most likely a significant number of initiatives to further support the well-being of colleagues across the trust. And finally, Chair, I know my teams, as well as many others, will have been heartened by your remarks about the important role that our corporate teams play in keeping the organisation running. So I'd just like to express my thanks to both teams for all the hard work that they've put in over the year, for their initiative and commitment and unending enthusiasm. Leave it at there, Chair. Happy to take any questions.
No, well said at the end there, Richard. I mean, as you've heard me say before, I think particularly on our internal staff comms, I do think Worcestershire Acute leads the way in terms of the foundation group. And lovely photographs, including one of our non-executive directors in your report as well. So questions and perspectives, Glenn?
Yeah, thank you, Richard. Really good report. One of the things I often wonder is how well the rumour mill is going from an organisational perspective. And I obviously link it a little bit to the freedom to speak up, because part of the ability of the rumour mill is for people to raise anonymous concerns if they wish to. What's your current experience?
I guess it would be, it's still well used, Glenn. We're still getting a significant number of questions in every week, which we're dealing with. Unsurprisingly, parking continues to be a hot topic. Well, the three Ps really: parking, pay and pension. But we've also had some other interesting questions raised. We respond to them, as I say, directly, but we also take some of the themes and feed those into the Exec Live areas that Steve and other colleagues touch on. And one of the things that we're looking at from a foundation group point of view is James at George Eliot, I know, has developed a kind of dashboard that sums up some of their rumour mill activity that I think we are about to borrow with pride, and then see whether that goes to people and culture, or how we tie it in with the intelligence that Mel's bringing through freedom to speak up, and also anything that comes through the staff survey and Exec Live, so that we can really get that kind of rich data about the issues of interest and concern. So that will hopefully be a development over the next few months.
That sounds great. Thank you.
Thank you, Richard. Please pass on our thanks to the team, and we'll move on to the Charles Hastings Education Centre update. Just before we do, I just want to reach out to trustees of the Charles Hastings Education Centre and thank them for their ongoing support for us as a trust. Tony, what would you care to pull out?
Well, I think Russell, the report's pretty self-explanatory. I'm happy to answer questions. I think, as you say, they're an important partner for us, and we should build a positive relationship with them, because I think there's mutual benefits to both of us in doing that. But as I say, happy to take an active part in that trusteeship and support them and the trust as far as I can. And as I say, happy to take any questions. Thank you.
Thank you, Tony. Any questions to Tony? Glenn?
Yeah, and I enjoyed meeting with a couple of the individuals who lead that, and as Russell said, just appreciate the work that they do to keep that facility moving forward. Really keen to take up the opportunity to work with them on the clinical simulation facility. So hopefully that's a business case that we can, between us, pull off and improve the training capabilities of the site.
Absolutely. And Karen?
Just a very quick one. You might not even know the answer to this. On page 145, it talks about a substantial bequest, and it just lists the number of noughts without the number. So I don't know if that's deliberate, or if there's a 1 or a 6 or a 10 in front of that, or if anybody knows.
I deliberately left the number off, Karen, because I wasn't sure there was a confidential matter between the estate and the trustee. So it is that number of noughts with another number in front of it.
That's fine. Thank you.
Okay, great. Thank you. Thank you, Tony. The Board of Sean. Gwenny, what would you care to pull out?
Nothing major to pull out. As you'll see, it's a little bit difficult to read in a current format. So I'm looking at a different format for the board. So it's just pulls things out a bit more clearly and enable us to focus a bit more on the actions being taken to close the gaps in control. So we'll be seeing that coming through in the coming months.
Yeah, it works better elsewhere in the foundation group, Gwenny, so I'm sure you'll sort that out for us. Any questions or perspectives to Gwenny? Okay, so I think we're on to any other business, team. If there's any other business, could you raise a digital hand for me? Now, I do think we've got some questions from members of the public. Gwenny, do you want to read these out, or is Joe going to read them out?
I can read them or sort of summarise them. I think what would be a good idea, because they're quite complex questions, the responses are quite complex, and we have a written response on each of them, if we append those to the minutes in the pack next time, because I don't think we can talk through them verbally. So the first question is about whether the Worcestershire acute hospitals includes single-sex changing rooms and toilets, particularly for women. So we have a response on that because it varies with what provisions we've got across the sites and across departments. We also have a question about the complaint system, the extent to which our complaints process complies with the policy, and any delays in responses, and the quality of the complaints process itself. So we have a response on that. There's also a question about learning from deaths and data in relation to various areas of the trust, including ED. And again, we've got a written response on that.
Okay, so I know the last few were from Ms. Harris. Was the first question from whom?
Member of the public, Karen Joyce.
Okay, so if I understand it correctly, we're going to provide the individuals with written responses, but attach those to the next set of minutes. Is that correct?
Yes, if that's okay with the board.
Okay, super. Okie dokie. Well, I think that therefore draws our meeting to a close. Can I be one of the first people to wish everyone who's watching the video a happy and safe Christmas? If you are aware of maybe a frail elderly neighbour or someone who's on their own, Christmas is one of the loneliest of periods for many people. So if you can just knock on a door, give a smiling face, maybe take a mince pie around if you can afford it. But just checking in on people at the moment is incredibly important. If you haven't had your flu jab and you are eligible to get your flu jab, can I really encourage you to make that happen? There is an awful lot of flu-like conditions around at the moment, which are, as we have indicated, causing us a number of operational problems. Help us to help you by getting a flu jab. And also, if it gets colder and icier, please do take care when walking around. Don't be embarrassed to use a walking stick. I do on occasion. It's better to use a stick than fall over. So in the meantime, I look forward to seeing you in the new year. For board colleagues, I suggest we have a 10-minute break and get going again at 4:20. Look forward to seeing you in the confidential board. Take care, everyone. Bye-bye.